No hay esperanza. Y me niego a creer que la salud es un movimiento.
Es una idea nueva, pero imaginar una salud proactiva, consciente y colectiva es falso.
La salud es un estado, y hay quien cree que la pandemia nos cambió.
Cualquier cosa es más importante que mi salud. La forma de ver las cosas puede cambiar tu salud. Mi salud es más importante que cualquier cosa.
La pandemia nos cambió, y hay quien cree que la salud es un estado. Es falso.
Imaginar una salud proactiva, consciente y colectiva es una idea nueva, pero la salud
Es un movimiento, y me niego a creer que no hay esperanza. Es tiempo de crear una nueva cultura de salud, bienestar, prevención, longevidad. Holadesalud.mx, un movimiento de TechSalud.
Hola, bienvenidos a este cuarto programa de Voces de la Salud, en donde hoy tendremos la oportunidad de conversar con Clifford Lane. Él es un médico investigador, graduado de la Universidad de Michigan, que ha pasado prácticamente toda su carrera profesional en el Instituto Nacional de Salud, en el área de alergias y enfermedades infecciosas en los Estados Unidos, en Bethesda. Ha participado en múltiples investigaciones básicas y clínicas. Participó activamente en los investigadores iniciales de la enfermedad del AIDS y tuvo la oportunidad de visitar China a los inicios de la pandemia y continuó colaborando y siendo un socio fundamental para el doctor Tony Fauci en la lucha contra el COVID-19. Muchas gracias de antemano, Dr. Lane, por el tiempo que ha estado con nosotros. Y ahora voy a cambiar mi conversación a inglés para establecer la entrevista con el Dr. Lane. Cliff, it's a pleasure that you've spared a little time of your busy schedule to join us and have a conversation with the students and faculty and the community of Tecnológico de Monterrey. It's a real pleasure to have you here today. So, as I mentioned to you before our conversation, what we'd like to do in the next 40 minutes is to ask you some questions about your interest in immunology, your experience during training, and the experience at NIH at your earlier years, and then talk about what has afflicted the entire world this past year and a half, which is COVID specifically. So, as I told you, I did a PhD in immunology. I do a little bit of immunology still, not in virology, and it's clearly dearly to me the field. But why wouldn't you maybe talk to us briefly about what sparked your interest in research in immunology and infectious diseases when you first started your career in this field?
No, thanks for that question. Thanks for having me as a guest. I don't speak very much Spanish, but enough to know you gave me an overly kind introduction. So thank you for that. I think like many people, what you do in your early training determines where you end up going for your specialty. So one of the things that I enjoyed as a resident was the field of infectious diseases. And one of the things I liked about infectious diseases was that you could see a patient who was relatively sick, but you could make a very clear diagnosis. And with that diagnosis, you often could find a very specific treatment and see that patient get better. So it was the clarity there of infectious diseases that made me interested in that as a subspecialty. At the same time, I was always fascinated by the diseases of the immune system that we would see, particularly autoimmune diseases. So when I was deciding to go into fellowship training in infectious diseases, I was looking for programs that actually combined immunology with infectious diseases. And there weren't a lot of programs of that type. And this now is, in the late 1970s. So I, learned about the program at the NIH, the National Institute of Allergy and Infectious Diseases, which is where I went for my fellowship. And as you noted, have been here ever since for many years. And it was a for me, it was a really being in the right place at the right time to study infections and immunity, because within a year of me getting here, we started to see the first cases of what became known as AIDS.
So your entire career at the NIH, and of course it's a prime institution where you have the ability to combine basic and clinical research. But did you ever thought about leaving or going back to Michigan, or consider going to a more or try a traditional university setting? It's amazing all these many years there, which is an incredible. But I was just curious to see if at some point you had doubts of being in the government for so many years.
Yeah, well, I definitely did. And it's a really good question, because, what are the sort of the pros and the cons of staying in a government position like at the NIH versus going outside of government to academia or private industry? So I can't remember exactly when, but it would be the usual time, a year or two after your fellowship. You can see where you are. You're trying to decide what to do. And if you've been relatively successful, get some publications out there, people start to recruit you. So indeed, the chief of medicine at Michigan at the time, invited me back to give a seminar, made me feel like I was somebody important when I really wasn't, and tried to encourage me to stay. He said, we'll give you a sabbatical. You can focus time on research. We'll protect your time for a couple of years till you get grants, and, you'd have like independence. And that all sounded great. So I came back, and my boss at the time and to this day is, as you mentioned, Tony Fauci. And I said, well, I'm working in your lab and you're my boss, and I really appreciate everything you've done. But, at a point in time, I'd really like to be independent. I'd like to have some time. I could do a sabbatical to learn some more fundamental molecular immunology, because that had become the focus of the field away from more cellular immunology. And he said, fine, you can do that. Independence, no problem. So he made such a good deal. As I say, I couldn't say no. Mm-hmm. The thing about the NIH that is different in the US from most, if not all, of the traditional academic programs is that you're judged retrospectively. So what happens is every 4 years, there's a review of what you've done, of your research. And if you've done a good job, then you basically get good funding for the next 4 years. And so it gives you a chance to actually fail. So you can take high risk. As long as every so often you do something worthwhile, it's a great environment for someone who really has research, I think, as their primary passion. While at the same time, I work in a hospital. In fact, in the clinic, August is my month in the clinic. I work in a full service hospital where everything is free for the patient. This is a fundamentally, key element of the NIH Clinical Center, where we can bring patients in, do protocols to either study disease processes or study new investigational products.
So I might have not understood clearly, but if you have a full-time position at the NIH and they assign you a category of research, will they give you funding, or do you have to compete like everybody else for funding?
The funding is part of your package.
Okay.
So my laboratory is fully funded.
Okay.
Every 4 years, I go before a board of scientific counselors. I tell them what I've done with that money, and they make a recommendation to give one more, which you never get, stay the same, or take away. And as long as you keep doing well, you've got a pretty secure future.
Oh, you know what? I was unaware of it. And as I mentioned to you, I spent many years in the U.S. and I participated in various grants proposals to the NIH, which is really hard, as you know. So this is a unique advantage of being at the NIH. Of course, you have to do your work at the 4th year mark, so you have to work pretty hard to make it renewable. But that's interesting. I was not aware of it.
Yeah, I think it's not fully appreciated. So the NIH has two components to it: what's called the extramural component and the intramural component. So the extramural is the grant funding to universities like Baylor. That's about 90% of the budget. 10% stays at the NIH in the intramural program with scientists, tenure track, staff clinician, staff scientist, more like a university structure, but a different funding paradigm.
Very, very, very good. So I may be exaggerating on this, but I assume that at the time of the HIV, the emergence of HIV, you were probably already full-time faculty at the NIH. And was that were you studying emerging infections at that time? Or what was your role during the early days of HIV, which has probably, I suppose, was just like COVID, well, maybe even more than COVID, I suppose, the devastation that created at that time. It was just, I remember vividly, I was a med student, I was in Houston, and, the first patients that we saw were just, nobody understood it. And so what was it like back then? And what was your role in trying to uncover mechanisms of disease, of this unusual acquired immunodeficiency condition at that time?
Yeah. So I came to NIH in 1979. So the first year of the fellowship is fairly clinical. The second year is research. So in 1980, 81, I'm working in the research lab. And what I'm doing is I'm actually studying the normal human immune response at the level of the B cell. So I'm studying B cell activation, differentiation. I'm immunizing normal volunteers with this protein keyhole limpet hemocyanin and seeing what happens, their antibody response, their T cell responses. So I'm really studying fundamental immunology in humans. And then all of a sudden, these reports started surfacing in the middle of 1981 of patients with this unexplained immunodeficiency. And there was a decision about that time to bring a team from New York Hospital to the NIH. So the team was headed by a guy named Joe Perillo, who was an intensivist.
Oh, Joe Perillo.
Yeah. Okay. Joe Perillo, yeah.
I remember. He did some work in cardiology, but I'm sorry.
Well, exactly, yes. And he went to Chicago after he was
Correct.
here, yes.
He went to Rush.
So Joe, before going to New York Hospital, had been a fellow with Tony Fauci doing some immunology work.
I see.
So Joe came in to run the intensive care unit, and he brought with him a guy named Henry Mazur, who was an infectious disease person, who had described some of the first cases of what then became known as AIDS in New York City. So gay men with pneumocystis pneumonia. So if you go back, there's a classic New England Journal of Medicine paper, December 1981, playing off the MMWRs from June and July, describing really what were the first case series of patients with AIDS. So Henry came with Joe Perillo. Henry started seeing some of the patients in the local area with this new disease. And he was drawing blood on them and sending blood to our lab. So we since we studied B cells, we were studying the B cells of patients with what became known as AIDS. And what was extraordinary was they had a polyclonal B cell activation. Their B cells were activated beyond the prototypic disease of polyclonal B cell activation, namely lupus. So the B cells circulating in the blood of the patients with AIDS were just spewing out antibody. The immune system, even though the patients were clinically immunodeficient, their B cells in the laboratory looked like they were hyperactivated. So you got this paradox of an immunodeficiency disease occurring in the setting of global immune activation. And that became a way that we began to tease out these different aspects of why the immune systems don't work. Two reasons. One is too few helper T cells, but number two, the high levels of HIV cause even the remaining cells to be hyperactivated and thus unable to launch a focused immune attack on the opportunistic pathogen. So it was Henry was bringing the blood. So I was getting interested that way. Then one day he came and said, hey, listen, I just saw a patient in the clinic who has an identical twin brother. Do you want some blood to see if I can get some blood from the brother? And I said, let's bring the brother here and see if we can do a bone marrow transplant. So this now is like 1982, 1983. So that started me really very interested in the clinical aspects. We ended up bringing in a lot of patients. We studied cytokine therapies, interferon, interleukin-2. We studied antiviral drugs, AZT, agents for OIs like foscarnet and ganciclovir. So we really developed a program to the point that, we had, they put a limit. The person who was the clinical director at the time said I could only have 10 patients in the hospital at once. So again, I'm doing this in what was called the Laboratory of Immunoregulation. Tony Fauci was the chief of the lab. I was then becoming a scientist in the lab. We didn't have the same formal structure, but you would view it as a tenure track sort of position. So we're bringing in the patients and doing the best we could, but it really was, as you say, an amazing time. Because basically, until we got to combination antiretrovirals, everyone just got worse eventually.
Did you do that bone marrow transplant on that patient? Or
Absolutely, we did. We started from that one patient. We started a program of adaptive transfer of lymphocytes and bone marrow transplantation, evolved that to genetically modified lymphocytes from the healthy twin into the donor. We immunized the donors with KLH so we could monitor the new immune systems in the recipients.
Wow. Oh, that's incredible.
Yeah.
That's
and we could see.
No, please.
I was gonna say, we could see some immune reconstitution, right? So someone who was allergic, they would get the immune system. All of a sudden, they had a delayed type hypersensitivity reaction to KLH. So we knew we were doing something. We just weren't doing enough because the virus was still there.
Mm-hmm. That's amazing. I have to tell you the story because you mentioned Joe Perrillo, and I said, is it the same person I know? Because he described this myocardial depression of sepsis. So he actually took serum from septic patients and then put them in culture cells. And I don't know who actually did that, or whether it's his lab or somebody else. And it showed that these heart cardiac cells didn't work as well. Well, I later on worked on one of the first descriptions of the role of tumor necrosis factor as a cardiac cytokine that affects contractility, that affects fibrosis, and eventually did human trials to block TNF in heart failure patients. And anyway, but a lot of that work, which was really inspired by Joe Perrillo's work, which I actually never knew that was prior to that, or I guess I never really questioned that, whether it was coming from where, because I couldn't really understand that what was the immunology link. And anyway, so that's an interesting story for me. So now let's say move the clock forward, and now we're at February 2020, right? And maybe actually December 2019, these case reports or the information, I suppose, I don't know if it was November, December, cases in China of this severe pneumonia. And then I think that you were asked to go to China in February, I suppose, or late January or February. Right. And I know you've publicly talked, but I would be really very curious to see what was your experience, and when you look at it with the eyes and our understanding today, how did it help you what you saw back then in China? How does that affect your view to the virus and the severity of the illness that you saw there? How does it compare to what we're seeing today?
Mm-hmm. No, those are great questions. Thank you. It may help just to set the stage a little bit, because I think there's a nice transition. At least I think so. So the first reports came out, early January, new pneumonia in China, new virus causing the pneumonia. We have some global programs, so we have some clinical research networks. In fact, we have one in Mexico called La Red, that with Guillermo Ruiz Palacios as the lead in Mexico. We also have programs in Guinea, Mali, Liberia. The Guinea and Liberia grew out of Ebola responses. The DRC also out of Ebola, and then Indonesia also out of influenza. So we had these programs, and I was visiting and working at the site in Liberia. And I remember watching cable news network, CNN, and seeing and this is now the middle of January, seeing that in Wuhan, China, they were building 2 large hospitals. And I'm thinking, wait, if there's just a few cases of a new pneumonia, why are they building these new 1,000-bed hospitals? There must be something going on that's quite different. And then obviously, over the next week or so, it became clear that this was a pretty serious problem in China. And I think it was around January 20th that really hit home for the US when there was this outbreak on the cruise ship. Mm-hmm. So the Diamond Princess cruise ship had this outbreak. There were Americans on the ship. There was now a case in Washington State. And so we were galvanizing into action at the NIH. And what we decided was, our vaccine research center was working to develop a vaccine. On the therapeutic side, we knew that the drug remdesivir, which we had actually studied for Ebola, had in vitro activity against coronaviruses. By extrapolation, we thought it would against SARS-CoV-2. So we were putting together a large clinical trial. Because there were Americans, in Japan and cases in Japan, we were going to have Japan as a site. So I was actually at the airport getting ready to board a plane to Tokyo to help with establishing a randomized controlled trial of remdesivir in COVID-19 when I got an email saying, you've been selected to be part of the WHO mission to China. And, I had not been to China, and I was like almost an overwhelming thought. So I called Tony Fauci, my boss, and said, I'm headed to Tokyo in fact, I'm on the plane by this time. I'm already, I'm hooked in through the Wi-Fi and doing email. And I said, I've got this invitation to do the WHO mission to China, but I really need to get to Tokyo to help set up the study. He goes, you need to go to China. So while I'm flying, if you can imagine this, from Washington Dulles to Tokyo, I'm basically online the entire time trying to figure out how to get a visa in Tokyo for a US citizen to travel to China. So as soon as we land in Tokyo, I went straight to the Chinese embassy to Japan, met someone after quite a delay who took my passport. And the next day I went back, got a visa, went to the airport. I knew that something was going to be different so I get to Narita Airport, everything's normal. I'm going to the gate to fly to Beijing. I got to the gate to fly to Beijing. Everybody had a mask on, except me. Get on the plane, fly to Beijing. Everybody had a mask on, except me. Landed at the airport, Beijing. I had not been there, so I didn't have a frame of reference, but I certainly had an impression. The airport was deserted. We were the only people deplaning, and it was a very eerie feeling because it's a very large airport. So I got to the hotel, sort of got with the delegation. So the trip then, the WHO mission was so interesting because there were several things, as you say, that really stuck with me. One was the messaging to the population. Again, it's a different society, it's a different government, it's a different culture. But there was no lack of clarity about the mission. The mission was to get rid of this virus. Everyone that you spoke with, and even in sidebars, at hospitals, at research institutions, we were quite busy for the entire 10 days or so of the visit, going to all different places, every aspect. I mean, we did see a lot. We didn't go to the Wuhan lab, and I'm sort of glad for that because that's become sort of a separate side issue. But everywhere we went, it was, we've got to control this infection. They had the experience with SARS, so they sort of had a plan. They had a game plan of what to do. And as infection showed up in different cities, and between us, we went to, I think, 6 different cities in China, you could see that same game plan played out. Closing the schools, contact tracing, isolation of the cases, and involuntary isolation of the close contacts. And you could see their numbers plummeted. I mean, they got control. In other words, the impression to me was, okay, with public health measures, you could control this. What was clearly wrong in terms of applying that outside, or at least other than some places like New Zealand, that you couldn't do that. So that was one thing, and with the consistency of the messaging and the effectiveness of those measures. The second thing was the fact that there was actually chaos when it came to treatment. There were all different things being used. And again, part of the reason I was on the delegation was to focus on the clinical research or the research aspects of the response in China. And I would talk to the different physicians and I would say, well, don't you have a priority for the research of what's most important to study versus would be interesting to study. No, we don't have time for that. We're too busy caring for the patients. I said, but if you don't have an agenda and a priority, how do you get any question answered? And I think if you look at the papers that came out of China, for the most part, from that period of time, it's a series of case series, anecdotal reports, not a lot of rigorous, what we would call randomized controlled trials. You know, maybe one that ended up being underpowered with a placebo-controlled trial of remdesivir. So that struck with me that really, you know, coming back to the US and debriefing people in the US, again, now this is towards the end of February. We were there from, I think, around February 15th to the 29th, something like that. It was quite striking to me how the same thing was now happening in the US, that everyone was trying something, everything was anecdotal. You know, this drug works, that drug works, everything worked. And it was really hard to get people to buy into the notion that you need a coordinated effort and you need to have priorities. And NIH, which typically works with its different institutes, needed to break down those silos, work together as one entity, work together bigger within the US government, and try to forge some public-private partnerships as well. So, you know, working with, you know, the leadership at NIH, something called accelerated COVID-19 interventions, therapeutics, and vaccines, ACTIVE, was developed as a public-private partnership. Well, at the same time, you know, our division of microbiology and infectious diseases took that remdesivir placebo-controlled trial, which showed benefit to remdesivir, and then expanded that to other studies looking at baricitinib, looking at interferon, looking at anti-GM-CSF. So again, it was a matter of looking at the importance of having a coordinated research effort as opposed to letting, you know, everyone do everything.
Going back at that time, say February 2020, right? Would you have imagined what happened? I mean, did you have
the rest of the world?
Yes.
No, absolutely not. Absolutely not. I mean, you know, what I was seeing was, okay, this was a little bit bigger than MERS, you know, or SARS. But, you know, it didn't appear to be, in a way, at least what we were seeing, that contagious like the super spreaders you had with SARS. There was containment. There was, I mean, if you look at the epidemic curves, they went up and they came down. You didn't see sort of the waves, and they maybe were going to have a small second wave, but it really, at that point in time, you know, I certainly did not have the impression we'd be in the global pandemic we're in today.
Is it the transmissibility of the virus that causes that, or the fact that it doesn't kill people at a, say, 90% lethality rate, or what is it? What is, in your opinion, what made it so globally present?
Yeah, I mean, I think, as the case with any, you know, genuine, you know, new emerging infectious disease, you have a very susceptible population. And if, I think it probably is, you know, I view it on a scale, you know, if flu is this level of infection and, you know, SARS 1, MERS is down here, that it's probably somewhere in between. For pathogenicity, it's also somewhere in between. So it, in a way, maybe hit a sweet spot, that it has, you know, substantial morbidity, but not so much that you don't have a lot of people who get infected and can spread infection. The thing about SARS-CoV-2 that I think is quite different from some of the other emerging infectious diseases is the asymptomatic infection, the fact that the asymptomatic person can spread infection, and the fact that there's a clinically silent phase in many patients, during which time they may have very high levels of virus in the upper airway.
So, Cliff, I think with all the advancements that we've seen in vaccine development, which is terrific, there is always the growing preoccupation of how do we stop the illness once it's established. And we see a number of drugs that may be effective, but we really haven't seen a blockbuster. And so what are you all doing at the NIH? What are your thoughts, or how far are we from really coming up with a real effective antiviral drug and why has it been so difficult, I guess?
Mm-hmm. Yeah, I think it's reflective, I think, of the overall challenges of developing a therapeutic for an RNA virus. We do reasonably well with the DNA viruses. They're more complicated usually. They have some pretty clean enzymatic targets that a lot of basic research has gone into describing. We don't have quite as much of a fundamental understanding of the RNA viruses, and their course is very short. So the challenges, I think, in COVID-19 is having a much better understanding of the pathogenesis of the disease itself. That we know you get this viral replication that can be asymptomatic, and indeed it may be the host response that brings in the symptoms. So you have this delicate balance between wanting to suppress the virus, but by the time you get to the patient, it may be that most of that viral replication has already run its course. And what you're seeing is the immune response to the virus, controlling the virus, but then going on to cause other damage. So the challenge is making a very early diagnosis to try to get in with an antiviral. And again, we see the monoclonals where they have effect. It really is when given early, or possibly, I think we'll see this come out more in the next few months, for hospitalized patients who haven't yet made an antibody response themselves. But once the host has made that immune response, there's a lot of tissue damage going on. So you see things like dexamethasone being shown to be of benefit. You see things like baricitinib, JAK kinase inhibitor, shown to be of benefit. Things like tocilizumab, blocking IL-6 receptor. So there, we're not really dealing with antivirals. We're dealing with the consequence of host response and tissue damage. What we need is to come up with better, as you say, small molecules, hopefully oral drugs that can deal with that early stage, rapid diagnosis, simple to apply therapies. The US government has just put forward somewhere around $3.15 billion for the discovery of new small molecules to develop better antivirals for diseases like COVID-19 and SARS-CoV-2. So there, we know with SARS-CoV-2 and other coronaviruses, there are some enzymes we might be able to attack, like a polymerase, like a protease, but there needs to be more fundamental research in targeting those specific enzymes of those viruses. So hopefully with time, we'll get something. Just having the drugs won't be enough. We need the early diagnosis as well, I think.
So, and that leads me to the idea or the concept of how is this going to end? Is it going to end because we really vaccinate a large proportion of the world? Or is it going to end because the virus eventually will slow down and something would happen to the virus itself? Or will it end because of a treatment that will abolish it? Because that's sort of in everybody's mind. I mean, are we going to get another Delta, which now it's called the Lambda or is Epsilon, or, with what we've seen today with virus mutating, not antivirals, and really a great proportion of the world not vaccinated. So how, if I force you to prognosticate, which is really hard, so I don't want you to see in the future, but what would be your gut feeling as to how is this going to end? I'm not asking you when. That would be a harder question. But
obviously, I was greatly humbled by what I thought coming out of China and what actually happened. So, it's with that same foreknowledge that I'll be completely wrong with whatever I say what I'm going to say. If you look at the other coronaviruses, you have 4 of them that cause the common cold that we just don't really worry about. Mm-hmm. You have one that caused SARS that seems to be gone, and one that causes MERS but seems to not be so human to human spread. It's still more of a zoonosis. This virus, on the other hand, I don't see that it's going away anytime soon. I almost think what will happen is the population of the world will adapt one way or another, that you'll eventually have some degree of immunity, you'll be exposed. Again, it's very unfortunate, I think, that this Delta variant, just by the random chance of, errors being made in viral replication was able to emerge because, the things prior to that were a little bit easier, although the antibodies work better against Delta than they did against the Beta, the one that originated in South Africa. I just think that we're in for a protracted course, and eventually without the same morbidity that we currently see. That would be my guess. Mm-hmm. And I hope I'm wrong, to be honest.
Well, I hope that we come up with the antiviral and maybe we get somehow vaccines more accessible to the world, because that's been really my more recent concern. You know, the U.S. government and I guess the CDC and eventually the FDA will recommend the booster shot for at least the mRNA vaccines in the U.S. for, I guess, for most of the population, I suppose. And I understand, I think you protect your own. But at the end of the day, if we have other countries where people remain largely unvaccinated and the virus is circulating, we will emerge again, like what happened in Wuhan. And eventually the common good of protecting the entire world will be in our self-interest. And that's a hard... I mean, I hope I guess you probably, or your colleagues have to make those decisions, right? But it's really a difficult decision to make. How do you really impact the rest of the world versus increasing protection locally? I guess it's a tough.
Yeah, I do think there's a very strong commitment by the current U.S. government to help provide massive numbers of vaccines to the world. I mean, again, there's 6 vaccines that are being greatly supported by the U.S. government now. The plans are to buy large amounts and donate them abroad. So again, even while there's talk of this third shot in the U.S., it's within a framework of, yes, the classic, now it's almost become a trite expression, no one is safe till everybody's safe. Mm-hmm. And as you say, this virus will continue to go from person to person until it either, hits everyone who's potentially susceptible or something else happens. I do think it's interesting to see the outbreaks in some of the less developed African countries hasn't hit them quite as hard, in fact, as it's hit the U.S. And that's sort of an interesting thing. I don't know if it's because of higher levels of innate immunity, exposure to prior things that are similar, or just age differences. But that's at least one good thing that I've seen in the epidemiology. But I completely agree with you. We have to look at this as a global problem and work together to get a global solution.
Yeah. Well, Cliff, we're coming towards the end of our conversation, and I'd like to really just thank you for your time, but also I'd like to make a comment for everybody to see. I follow work from many investigators at the NIH for many years, and a lot of what we know for illnesses like this ones, like HIV or many other guidelines for treatment of complex conditions, comes from work at the NIH, and in some way I think that a lot of the good that comes out of it benefits the entire world, not only the U.S. So I applaud that effort. I think it's great, and all the work that you and your group and Dr. Fasci has done for combating COVID-19 in the U.S. really has helped and set the standard for many of the things that we do in Mexico and all over the world. So I admire that, appreciate it, and it's really been a pleasure to have you here with the tech community. Thank you very much for your time, Cliff.
Thank you.
Muchas gracias a todos por su atención. Realmente tuvimos una conversación extraordinaria con el Dr. Lane, a quien nuevamente le agradezco por el tiempo que estuvo con nosotros y compartir tanto su experiencia de vida como todo el expertise en el área de enfermedades infecciosas y en la lucha de los Estados Unidos y los institutos de salud contra del COVID-19. Gracias a todos por el tiempo que compartieron con nosotros y espero que esto haya sido informativo y también productivo para nuestra lucha contra el COVID-19.